So I'm very excited about our next speaker. And it's time for a little international flavour, actually. Originally from Nebraska, our next guest has also had an incredible career in nursing, including stints as Associate Professor at Yale School of Nursing and Adjunct Associate Professor at Kansas University School of Nursing. She is double certified as a clinical specialist in adult psychiatric mental health nursing and as a psychiatric rehabilitation practitioner. She's also president of Nurse Seminars, Inc., an international consulting and lecture firm related to psychiatric nursing. She served on 2 task forces for the US National Institute of Mental Health and was honoured as a Fellow of the American Nurses Association. Her list of research papers, publications and awards is far too long to go into now. Would you please give a huge welcome, put your hands together, for Dr. Mary Moller.
Well, good morning. I have been looking forward to this since Murphy first contacted me in November of last year. And I know now that I'm the one with the accent. So it's wonderful to listen to you all. So I hope that you can hear me okay and understand me okay. I would like everyone to stand up. You've been sitting for a while. Okay, do a little neck roll and all of that. But I want to do a little poll. So would everybody who's not a nurse please sit down? Okay. Now, if you have been a nurse 1 year or less, please sit down. Okay. If you have been a nurse from 2 to 5 years, please sit down. If you have been a nurse from 6 to 10 years, sit down. Too bad the minister isn't still here to see the dedication in this room. If you've been a nurse 11 to 15 years, sit down. Wow, okay. 16 to 20 years, sit down. 21 to 25. Okay. 26 to 30. We'll be bringing the walkers out shortly. 31 to 35. Okay. 1, 2, 3, 4, 5, 6, 7. 36 to 4. We should just do now 36, sit down. 37 years a nurse, sit down. 38. We do keep track of how long we've been nurses, don't we? 39. 40. 41, 42, 43, and I'm 44 this year. Anybody else 44? Sit down. 45, 46, 47. 48. And the oldest nurse in Australia. 49 years. 50. 50 years this year. Woo! Who's 52? You sat down too early. That's why. 52 years. Okay. So my talk yes. And I understand that you have done marvelous things as the first national nurse. Is that correct? First director of nursing for the country? Congratulations. Well, my background is quite varied. I never wanted to go into psychiatric nursing at all. Oh, well, first of all, I need to say that when I had this email from APNA, I thought, well, why would I be getting something from APNA? Because I am a member of APNA. That's the American Psychiatric Nurses Association. And I was president of the APNA in 2010. And when I got this notice from Murphy, it was just a month after our national conference. I thought, well, what is that? So anyway, I said, of course, it's APNA. Of course, I'll come anywhere that's an APNA. So, of course. I am originally from Nebraska, and left my home state to go to Washington State in order to take full advantage of the Nurse Practice Act, which allowed master's prepared nurses to be an independent practice and autonomy. And I never wanted to, I wanted to be a midwife. That was my original goal. But, you know, God puts us here for various and sundry reasons, and we never know exactly why it is. But certain doors open and other doors close. So I wanted to, while waiting to become employed on the OB unit, I got stuck on neurology. And I really didn't want to work in neurology because everybody would have something wrong with their brain and they wouldn't be able to talk and there'd be closed head injuries and all that horrible stuff. And anyway, I grew to love the brain. And I'm going to be showing you some brain scans actually in this talk a little bit later on. And it was actually my first foray into psychiatric nursing, only I didn't know it at the time. So 7 years flash forward, I have had a couple of children, and I got into teaching and a diploma program and got drafted into psychiatric nursing kicking and screaming because the coordinator of the curriculum said, it's your turn to cover an overload of students in psych, and it was in the spring of 1978. And I thought, oh, it was punishment for getting in trouble as a student, which I did in psychiatric nursing. We don't have time to go into this story, but suffice it to say I got put on probation. I said, don't worry, I'll never work in psych. It's okay. Be careful what you say. And she said, don't worry, we'll put you where you can't hurt them. We'll put you out at the county hospital. I was like, oh, my gosh. So I walk into this building, and it said, welcome to the Douglas County Poor Farm and Pestilence House. It was horrid. But anyway, I thought, oh, my goodness, this is... was fascinating to me. And I thought, well, you're supposed to be afraid of psychiatric patients, right? You're supposed to be afraid of mental health. And I thought, I feel like I know these patients. Why do I feel like I know these patients so well? And I thought about it, and I went, oh, this is just hallucinations, delusions, talking weird, acting strange, and thinking weird. This must be where people go when they leave the neuro unit. Except in neurology, if you had hallucinations and delusions and abnormal speech and you didn't get along with your family, that was an urgent situation, wasn't it? Because that meant that whatever was going wrong in their head was worse. And so I was trained up in that, and I was in neuro rehab for quite a while. And so over here in neurology, if you have these symptoms, it's very serious. Over here in psychiatry, if you have those symptoms, you're given another 1,000 milligrams of chlorpromazine, you're put in seclusion and restraint, and you're told to, straighten up. And I was so angry at that disparity, I thought, oh my gosh, and I was getting my master's degree in medical surgical nursing, and I thought, I'm going to switch to psych. I think it's what I'm supposed to do. And it's the best thing that ever happened to me. So I brought my neuro nursing and my neuro rehab into psychiatry and developed a wellness approach to psychiatry. And we reduced rehospitalization by 93.5%. And it's been replicated all over the world. Thank you. And it's a nursing model. And you can read all about it in my new textbook, which was just published in January, called Psychiatric-Mental Health Nursing: From Suffering to Hope. And it's published by Pearson, and I would really encourage you to get it because it's all about our wellness approach to mental health nursing. So all that being said, I went to Washington State, and I thought, I have to get out of hospitals. I can't stand it. We have to get to where to help people live fuller lives. And so I started the very first outpatient, nurse-managed, owner-operated rural psychiatric clinic in the United States in 1992 in Spokane, Washington. And it was an experiment to be a living lab for consultation and program development. And it turned into an extraordinary 16 and a half years where we had 4 prescribing ARNPs. That's my licensure, Advanced Registered Nurse Practitioner. We had 4 graduate students. We had a drug and alcohol social worker. We had a child adolescent counselor, our office manager, and our therapy dog. And we rock and rolled with keeping people out of the hospital. In 16 years, we had 9 hospitalizations. That's all. And we serve people with serious and persistent mental illnesses. So, why? Because it was a nursing model. It was not a medical model. I love my physician colleagues. I just kind of feel bad for them because they're very narrow. And, as nurses, we look at the big picture. That's what we're trained to do. And physicians are trained, what do we have right now in front of us? So we put us together, we have a team. It's a great team. It's been very fractured now with healthcare revolution, I guess. I don't know what even to call it anymore. Demise. I think it's the demise. And it will be nurses that save our healthcare system. It will be nurses in the community back where we were in the beginning. So I have some remarks that I've put together about psychiatric nursing. So there we go. So every primary care nurse is a mental health nurse. You just didn't know it, right? And a lot of people think, well, I don't want to be in psych. Excuse me, we are. Okay, we are in psych, all of us. And I'm going to talk to you a little bit about that. So let's see if I can make this work. Okay, so this is all about me. So right now I was in charge of the psych nurse practitioner program at Yale University School of Nursing. And when we moved to Connecticut, I didn't have any grandchildren, and now I have 4 grandsons. And it changes your life. So 2 of them were in Nebraska, and we could hop to Nebraska pretty easily from Connecticut. But getting to Bremerton, Washington, where my other grandsons are, which is an hour-and-a-half drive after you get to Seattle, I couldn't do that in a weekend. So teaching position came up, and it was a God thing. And I said to my husband, let's go back west. So we just went back west last summer. So now I'm at Pacific Lutheran University, and I'm creating a bachelor's to DNP for psych nurse practitioners. So we will be admitting our first students this summer and starting the psych courses next fall. All right. So I have some objectives for us. I want you to think about some terminology. I want you to think about how we can discuss the treatment of these disorders in primary care. And one of my stints in practice in Connecticut, I was in a federally qualified health center, FQHC, that's what they're called in the States, where they're primary care clinics that provide full range of services. So they wanted to figure out a specialized service for psych in primary care, and I went to help do that, and we developed what was called co-located care. Wasn't truly integrated, but co-located meant we had psychiatric provider at the clinic site, and so we would get the referrals. And the goal was to keep the patient at the clinic instead of sending off to specialty care. So I'm going to talk about that for a little bit. And I'm going to talk about medical conditions in psychiatric patients. So you see, you have people who come in with the chronic illnesses, and one of the biggest chronic illness in the world is depression. And that is probably subsequent to the effects of trauma, abuse, neglect, violence. So we're going to talk about those coexisting conditions that impact on a person's mental health, which then obviously impact on your physical health. So we have 2 groups of people. We have people with a primary psychiatric illness that are relatively healthy, but they need some care, their ongoing care for their mental health concern. And thank you so much, Zara. Where are you? Where'd she go? For sharing your story. It's so important because that's how we bust stigma, right? So you had a serotonin goof up, and I'm so glad you're here to tell us about it. Okay? And then we have people who have medical conditions that have comorbid psychiatric conditions. So we don't have a dualistic view of the world anymore. Descartes did have an error, okay? The mind and the body are not separate. The mind and the body are one. And the last time I checked an anatomy book, the blood that flows up here flows down there, okay? So we are a unified being, and that's what we in nursing do, is we treat unified beings. So I want to talk then about the role of the primary health care nurse in integrating treatment. So I was doing a lot of research of what's going on in Australia, and the word integration here is trying to coordinate, means a couple of things, trying to coordinate just all the different varied primary care resources in the country, as well as then incorporating behavioral health care into primary care. So we have a very global problem of untreated mental illness because of stigma. So in this, I was thinking I was going to have my monitor right here so I could read them, and now I was like, okay, I'm going to see this monitor down here without, I guess I could see it over here just as easy. So we want to look at what the World Health Organization has done at looking at mental illness. Did you know that in this report in 2002, that it was the first time the WHO had looked at mental health globally? Oh, that helps. Thank you very much. Okay. I'm ask and you shall receive, right? Okay. Let's see. Maybe there's some other things we could have him do. Okay. Okay. Yeah, my husband's okay. All righty. So if you look, okay, now they told me I have the laser. Okay, can you, oh, right, so I have to look up here. Okay, so 26% of the disability on the planet is due to mental and behavioral disorders, okay? You can read the rest, 14% musculoskeletal, moving on down to neurological, infectious disease, respiratory, injuries, endocrine blood, immune disorders, cardiovascular, and GU. So when we look at this, but people don't want to address it. And a lot of the problem is that you see the questions aren't asked. The patient isn't queried. Because you see, if you ask and you get an answer, you have to deal with it. So if you don't ask, right, you don't have to deal with it. And I don't know, in your model of care here, are the visits set at 10 to 12 minutes apiece, or are they a little bit longer? Yeah. So, you have the whole day set up for your coding system that, the patient is coming in with a right earache. And, so that everything is set up for that care. So if the patient also has a concern with their left ear, then you can't deal with that on that visit. You have to make another appointment, right? Because it wasn't scheduled in. So who's going to talk about bringing up something as complex as eating disorders or psychiatric conditions? Because then it's going to screw up the schedule. So we have a fundamental revolution that needs to happen in the delivery of, it's all related to financing, so that we can have adequate time to give to patients. Okay, so some general statistics. 57% of the population knows someone who's been diagnosed with a mental illness. 1 in every 5 adults has a diagnosable mental illness. So if we take a room of 500 people, we've got 100 people here who are dealing with something. Depression, anxiety, eating disorders, trauma and abuse, post-traumatic stress disorder, okay, bipolar disorder. And these don't mean that you can't be a nurse and you can't be a normal, regular human being. It's just another body system that needs to be managed. It's called the nervous system, and it has to be managed, and it's nothing to be shameful about. 1 in every 4 families have someone with a mental illness. 1 in every 5 children and adolescents have mental health problems, but only a third of those are getting help. Worldwide, 20% of prison inmates have a mental illness, okay? And 2/3 of elderly nursing home residents. So we have, a lot of people. We have around 10% have major depressive disorder. I'm going to show you what it looks like in a brain scan here in a little bit. 1.2% of bipolar, 2.8% generalized anxiety disorder, 1.7% with panic disorder, 2.3% with obsessive compulsive disorder, 1% with schizophrenia, 1% with dissociative identity disorder. This used to be called multiple personality disorder. And dissociation is on the rise, related very much to stress and anxiety. 3.6% have post-traumatic stress disorder. Now, the interesting thing about post-traumatic stress disorder is that many people within 2 years after a trauma show symptoms, but after 2 years, it has resolved. So PTSD is most treatable. We know that 14% of people have dissociative states. So dissociative states is sort of what being an adolescent is all about, okay? So it's zoned out, okay? You're just zoned out. You get triggered, you get zoned out. Now, we all have many dissociative states. How many of you have had a very busy day at work, and you get in the car, and you drive home, and the next thing you know, you're in your garage. You go, did I go over the bridge? Did I go by the park? I don't remember going by the mall. How many of you can identify with that? Yes, okay. That's a dissociative state. You were not conscious while driving. Your body was on autopilot, and your eyes were working on autopilot, okay? That's a dissociative state, but you snap out of it. So we have many of our patients who have serious physical illnesses go into a dissociative state with the presence of bad news. So, for instance, my husband, who was a very heavy smoker, and he quit in 1999 because he wasn't going to go into the new millennium with smoking, was diagnosed with COPD, so it caught up with him. And, of course, being a typical man, he wouldn't go when he was really starting to get respiratory distress. So he went to the doctor just in February, and he only has 34% lung function. 34%. So now he's on 2 inhalers at $600 out of pocket a month to do. And the doctor said you have very severe stage 4 COPD. And my husband zoned out after that. And he comes home, and I said, I wasn't with him, because he scheduled his appointment when I was teaching because he didn't want me there. And I said, but you know what? You're probably going to hear some things that you don't understand. So anyway, I went to see the doctor, and I said, I can't believe you didn't give him any pulmonary rehab. I can't believe you said go home and come back in July. He said, oh, I didn't do that, Mary. So he said, well, he probably didn't hear anything after I said he only had 34% lung function. I said, you think? So anyway, I said, how about a drug study to get some of these meds free? But anyway, so then my husband goes, well, I don't want, an erection that lasts for 4 hours. And I said, I don't think that's going to happen with your inhaler, dear, Yeah. It might be kind of interesting, though. It's been a long time, Decreased oxygen affects lots of things. I better get back on track. Okay. So anyway, the point being is that our patients, when they get bad news, they don't hear it. They don't hear what you say. They don't hear your medication instructions. They don't hear when they're supposed to come for their follow-up. So then they get blamed. Well, they didn't show up. They were a no-show. You screwed up the whole clinic, so it's a no-show. You know what? I bet they didn't hear it. Or you may have given them the card with their next appointment, but they don't even know where they put it. So we really need to be doing a lot of, teach back, saying, okay, you've just been told this news. We need to talk about this news. I need you to tell me what it is you think I said. I need to understand what you understand so that our patients can go out. We can bring them back in to reality. And I haven't even mentioned substance abuse. So if we have substance use going on at the same time, we have a triple whammy. Okay. 12% of people have phobias. 1% of adolescent girls have anorexia. 9.2% ages 12 and over used illicit drugs in the last month. It's just frightening. 7.3% of adults are substance dependent or abusive with substances. About 20% are current drug users between ages 18 and 25, and almost 20% of youth report binge drinking. So in our country, who's getting the care? Not very many. So if we've got 44.7 million adults, which is about 18.6% of the population, and only 41% of those are getting treatment. So about 9.6 million have serious mental illness, and 62.9% get treatment, 2/3. 5.2 million of children, which is 21% of our population, and only 20% of those, 5.2 million, are getting treatment. We have 2.7 million children ages 8 to 11 with serious emotional disorders, and which is 11% of our total population, and only 53% are getting help. So when we start looking at what's going to happen to these kids when they grow up, they're going to end up in jail. Adolescents with any mental illness is about 12.5 million, which is half of the total adolescent population, and 40% are getting treatment. And older adults is about 8.8 million, 20% of the total population, and less than 3% of our older adults are getting care in the United States. It's bad. We had to close our clinic in the end of 2008 because the state was 6 months behind in paying us our reimbursement for our Medicaid patients, which is what your Medicare is. It's Medicaid in the United States. And I was MasterCarding my payroll. Well, you can't do that for very long. So, okay. So in looking at the health status, then, of people with mental illness, just in October, there was a very brilliant study done, reported on. The study's been going on for a while, but I've given the website, and these slides will be posted so you can have access to them, so you don't have to worry about taking a lot of notes. But this website is out of the University of Illinois in Chicago, and they are focusing on what are the medical illnesses in patients with psychiatric disorders. So they studied consumers who'd gone to health fairs. So the consumer groups in America are quite prevalent and very well attended. So there was 457 people in 4 states that agreed to be in the study. And they really were matched studies, ended up with being very similar folks in there. So here's what we have. Okay, so when we're looking at obesity with a BMI of 25 to 29.9 overweight, of that sample, 22% had that BMI, but in the general population, 33% are overweight in the United States. But of obesity, 60% of the people with mental illness, compared with 36% in the general population. So we can look at cholesterol, diabetes, but if we look down here at smoking, people with mental illness smoke the majority of cigarettes. And so we have medium Smokers, 44%, there was 200 of the sample, compared to 19% of the general population, and heavy smokers, 62%, compared with 57% in the general population. So our people are sicker, they smoke more, they have more alcohol use, and they have more heart disease. And a lot of this is traced to the psychotropic medications, because psychotropic medications are by far from flawless in what they do to the body. So when we look at the health problems or their health risks, so we look at, of this sample, people who had had stroke, asthma, chronic bronchitis, emphysema, ulcers, etc., compared to the national prevalence, our folks are sicker. So we look at hypertension. So of this sample, 44% compared to 25% in the general population. Hyperlipidemia, hepatitis A, B, or C. So people with mental illnesses they die 20 years younger than an age-matched cohort of people who do not have mental illness. Part of that is because of what's going on in the brain and the central nervous system. The body does not relay back to the brain in the proper feedback mechanism. So it's not uncommon for a person with schizophrenia, for instance, to think they might have a little bit of a cold, and it's full-on bronchitis and pneumonia. One patient I remember in particular taking care of many years ago that complained of a side ache and kept complaining about it, and finally took the patient into the ER. It was a ruptured appendix. So the pain mechanism doesn't feed back in the same way. So our people are sicker, and a lot of times they don't even know it. So then we looked at the same group of who were getting treated, and quite a few of them were actually getting treated, but certainly not 100%. So those who were getting treated were lucky enough to find primary care that would take them. Okay. So now when we start looking at what is common amongst many people coming to primary care, not necessarily with a diagnosed psychiatric disorder, but trauma and abuse. So your favorite patient rings up the phone, and the nurse who answers the phone goes, everybody knows who you're talking about. So it's the patient that has asthma, they have migraines, they have GERD, they have obesity, they have some type of metabolic syndrome, they have chronic pain, they have a lot of anxiety, right? So it's this patient that's got everything rolled into one. You know who I'm talking about. Okay, that patient, I would lay my life, is a victim of trauma and abuse and has been a survivor of some type of abuse, trauma, neglect. So how many of you are familiar with the ACEs study, the Adverse Childhood Events Study, ACES? Raise your hands. Okay, great. Some of you. So what I want you all to do is to become very familiar with the ACEs study. The ACEs study, and I've given you the website, it's just acestudy.org. So what they looked at was, what does trauma and abuse do to you as you move through life? So maybe I'll move over here and let you guys have this one, okay? So if you have an adverse childhood experience, it leads into social, emotional, and cognitive impairment. These kids don't do as well in school. They end up with ADD oftentimes, or something that looks like ADD. Maybe it's post-traumatic stress disorder. And they have very risky health behaviors, ended up with disease and disability and early death. And this is a very common trajectory. And a lot of patients end up dropping out of care because they don't feel like their needs are being met. So this was a study that was done at one of the Kaiser Permanente facilities on the West Coast. It was done in Southern California. 17,421 adults. This is what you call a statistically significant sample, okay? So here was the percentage of abuse that they did experience. Whoops. Go back. Okay. So 11% had psychological, 28% physical, 21% sexual, neglect, 15% emotional, 10% physical, household dysfunction. 27% of these people came from a substance abusing household. 23% had parental separation, divorce. 17% had mental illness in the family. 13% were in domestic violence where their mother was battered. And 3.4% had a family member in jail. So it would be interesting to replicate this in an Australian sample. I would lay you odds that the percentages are the same. So what happened is they looked at how many ACEs you had. So normally we think getting 4 ACEs is a good thing, but getting 4 ACEs in a trauma study is not a good thing. So this study then looked at how many had 0. So about a third of the population was okay. They did not come from any type of traumatic background. 24% of women, 27% of men had 1 ACE. 14% of women, 60% of men had 2. 3 was 10.4, 9.3. 4 was 6.8, 4.8. But greater than 5 was 12%. So we know, so you're going to go, okay, so what? Well, it's a big so up. So compared to an ACE score of 0, if you have 4 adverse experiences, it was 7-fold increase in alcoholism, doubled the risk of being diagnosed with cancer because of the stress on the immune system and what was happening with cortisol production in the body, 4-fold increase in emphysema, and an ACE score above 6 was associated with 30-fold increase in attempted suicide. Just got a very disturbing statistic this past week that in the United States, 20% of all suicides last year were veterans. 20% of all suicides in America last year were veterans. So we have a lot of chaos happening in our world. So what are we going to do? People with mental illness used to receive their care in state systems, but those are all closed down. So now these victims, and also, so they're in our clinics, they're everywhere. And people say, why do we have so much more mental illness? We don't have more mental illness, we have more visibility. And we also, people who are victims of trauma are not properly screened in primary care because of a time factor. It's not a blame factor. But this is something that nurses can take and say, this is our thing. We collect social histories. So on the website, there is the ACEs checklist. It's the rating scale. It should be given to every single primary care patient. And before they're ever seen by the physician, you should say, we have an ACEs score of 6 here. So we know we have somebody that's probably going to be pretty prone to suicidal thinking. There's something going to be anxious. And if they've got emphysema and if they have substance abuse, you know, you can give them all the medicine you want in the world. But if we don't deal with the trauma and deal with the aftermath of that and the acknowledgement, a lot of times it's just acknowledging and that people can feel accepted, that it can help turn their lives around. So this is very much in the nursing purview. All right, so you have some great policies going on in this country. I'm very impressed with what this country is wrangling with mental care of mental health needs in primary care. So this first website, this is the American Association of Family Practice, looking at embracing the need for every single primary care provider to become also a mental health provider. And Basilon.org is a huge policy group that has made the same statement. So everybody's pushing for integrated care. So integrated care means 2 things. Here you're trying to integrate just all the varied primary care settings that you have in the country, but it means integrated behavioral and physical care. So it's a care that's involved with a team, and nursing is very much part of the team. One of the biggest aspects of that nurses can do are create care management systems, which I will talk about in a second. So the WHO has addressed this, and they're going, okay, so what do we know about when we integrate mental health services into primary care? Big thing is better accessibility, improved human resource capacity, better prevention, better treatment rates, quality. You're going to get better satisfaction surveys. But the biggest thing is reducing stigma and discrimination. So people with a psychiatric illness don't have to go somewhere else other than to their primary care setting, the community-based setting. And the most important aspect is home health. Psychiatric home health is really, it's fascinating. Are any of you psychiatric home health nurses here? Well, of course, my good colleague, Kim, from your Australian College of Mental Health Nurses. Okay. So that is another big areas to look at, home health. So who's getting treated? So we need to know, in your country, are psychiatric patients being treated in primary care? And is primary care providing care in mental health facilities? So we have 2 levels. Some people are very seriously mentally ill. And about 75% of people with a psychiatric illness can be very well cared for in a primary care setting. But about 25% have such disabilities in their brain that their ability to navigate a primary care system, they can't organize themselves enough to navigate. So primary care services are being provided to the patients in mental health settings. So your had a big national media initiative, Mindframe. Some of you may be familiar with that. Great statistics if you want to look that up. And then, of course, your mental health services in Australia group has published a big study just in December of 2014. So I'm going to give you some information from that. So your beds in Australia have decreased, just like ours in the United States. You have reduced to, when we look at this study, starting in 2002, there was this huge reduction. This is beds per 100,000, and it's determined that you need 50, a minimum of 50 inpatient beds for every 100,000 population. So you're well below, and so is the United States. We have some states in America that have less than 20 beds available. Where I live in south of Seattle, in Tacoma, Washington, we have 180,000 patients that meet criteria for serious mental illness, and there's 11 psychiatrists. That's it. So all the care is being given, like people by myself, advanced practice nurses, because there's only 50 psychiatrists in the state of Washington that live outside of Seattle. Okay, and I would imagine you have a very similar, that you have people just, conglomerated in the big urban areas. So they have to be given care somewhere, okay? So we know that there's about 7.3 million, or 45% of Australians, that will experience a common mental health-related condition, such as depression, anxiety, substance use, in their lifetime. And you had a second national survey of psychosis in March of 2010 that said there was about 64,000 people with a psychotic illness in the country, and about $7.6 billion per year is spent, and that includes residential, community, hospital, and consultations, including consultations with GPs. So there was a wonderful, wonderful, wonderful report given by one of your very famous psychiatric researchers, Asen Jablensky. That will be a great resource for you to have as well. We know that about 12.3% of GP encounters were mental health related in 2012, and that's an average annual increase of 4.7% in the number of mental health related encounters. Now, that's not encounters with someone who had diabetes and you find that they have depression that go along with it. These are people seeking services primarily for a psychiatric disorder, and depression was obviously the most commonly managed health problem. So here's the national statistics on lifetime prevalence of depression. When we're looking at about 25% of the population in the middle adult years, 35 to 44. But how many people who have multiple physical symptoms really have depression as the underlying nature? Now, this was a fascinating study. It's a very quintessential study done back in 1994, but it was done in primary care patients, 1,000 of them. So this was the linchpin study after which a lot of the other data was collected, looking at simply the number of physical symptoms that were being presented by the patient. So if they had 0 to 1 symptom, there was a very slight chance there was a psychiatric disorder, and the green is a mood disorder. 2 to 3 symptoms, it bumped up to 20%, 4 to 5, 30-some percent, 6 to 8, 50-some percent. If they had greater than 9 physical symptoms, it was about a 75% chance that it was primarily a mood disorder. So, and that fits with the ACEs study. So this came out a little bit before the ACEs study, and this really mirrors what happens with early childhood adverse events as the person ages. Because when a great question to ask when you meet a patient for the first time, a very simple question is that, do you feel afraid more hours a day than you do not feel afraid? Do you feel afraid more days a week than you don't feel afraid? And when you start getting patients telling you, yes, I'm afraid, and you say, okay, well, can you tell me what kinds of things you're afraid of? And maybe they'll want to talk to you about, domestic violence, maybe not, maybe substance abuse. But if you approach it by, do you feel safe? Most people say, oh, yeah, I'm safe. But if you say, how many, do you feel afraid more hours a day than you don't feel afraid? When a nurse asks that question, because we're trustworthy, patients are going to answer you. Okay, and it doesn't take more than 15 seconds to utter that question out of your mouth. Then you can say, okay, so let's take a look at how some of these symptoms that you're experiencing today, maybe they're getting worse because you are living with a lot of fear. And maybe the fear is, not related to domestic violence, but you don't know what the fear is related to. But the fact is, if somebody feels afraid more hours a day than they feel safe, that tells you their cortisol is pumping, their noradrenaline is pumping, and they are going to end up with cardiovascular, and they're going to end up with autoimmune problems. It's a given. It's just a given. So this was another very quintessential study published in '97 based on that first study with looking at 100 depressed patients that appeared in primary care. Were they diagnosed with depression? 50 yes, 50 no. Were they treated? 25 yes, 25 no. Were they treated to they felt better till they had remission? 8 out of 100. And I would say that's pretty much still holds true. So if we don't deal with the depression, then we don't shut down the cortisol, we don't shut down the noradrenaline, we're sucking dopamine and serotonin faster than it can be produced, and the body will break down. Okay? 14 different serotonin receptors in the body, the bulk of them are in the gut. What are people coming for treatment for? GERD, irritable bowel, GI upset. Okay? The other ones are up and down the nervous system. People have, what are they talking about? Chronic pain. Okay, chronic anxiety. So when we're looking at serotonin, it's really an important neurochemical to talk about. So you can give somebody an antidepressant, which they do, which is, okay, fine. Okay, so you're going to take some citalopram or something like that, or some Prozac. Well, if the person is still living in fear, medicine won't work. Okay? So we have to, in order for the medicine to work, the medicine has to be in enough concentration that it can produce something called brain-derived neurotropic factor, that's our homeostasis in the brain. And if we're living in fear, that conversion doesn't happen. So people will say, well, I'm not going to take this medicine, it doesn't work. And say, well, tell me about your medicine. Well, I've gained weight, I'm sexually impotent, I don't like the way I feel, and I'm flat. So I'll say, oh, your medicine's working fine. But you're only getting side effects. Okay, why are you only getting, so it tells me that it's going into their body. If you're getting side effects, the medicine is working, but they're not able to get therapeutic effects. So when you hear that, you need to stop and think, wow, do we have trauma, abuse, neglect, violence, substance abuse, depression? What is going on in this patient's behind their door that is causing some of these symptoms to maintain? Okay, so the most common management that was done was simply to prescribe a medicine. Okay, so 63%. For every 100 mental health problems. So that brings up another point. Is it mental health or is it mental illness? Every single one of us in this room have mental health needs every day. Trust, safety, security, control. But thank heaven, only 1 out of every 5 has a mental illness where there's actually changes in the nervous system that affect a person's ability to function. There were 2.4 million Medicare subsidized mental health related services in 2012-2013. Females age 35 to 44 are the highest consumers of Medicare subsidized. Okay, so if we look at how these encounters, mental health encounters, are increasing, you can see this. Okay, and if we're looking at how its percentage rates per 1,000 population is really increasing. So if you look at these by age groups, okay, so we're looking at the blue bar is the percent of total mental health related encounters, and the gold bar is the rate per 100 demographic group specific encounters, meaning the general number of encounters. So if the physician was seeing our highest rate here in our elderly, okay, so about 25% of the elderly visits of these 65 and over were related to mental health. So we can see it's pretty even. The people coming in here in this mid-age range, they're really looking at mental health related problems. So many people say, well, I don't want depression, I'm not mentally ill. You say, right, you're not mentally ill. You have a serotonin problem, or there's a dopamine problem, or whatever physiology is going on. And the other factor that interferes with this is worry. So another question that you can ask your patients is, do you worry more hours a day than you don't worry? Do you worry more days a week? More weeks a month, more months a year? So if people are worrying, they are sucking dopamine, because it takes dopamine to mull a question back and forth. Like, well, if I do this, if I do that, that's all sucking dopamine out of your brain. Well, dopamine also is what's needed to run your heart, lungs, liver, and kidney. So when people then have a chronic lung disease, chronic cardiac disease, and they're worrying, they will have depression. It's a given. So you can treat the depression, but if we don't treat the worry that's driving the depression. So this is what nursing does. We sit and we talk to people and we listen to people. And we go, you know what? Wow, you are really doing fabulous in spite of a lot of really difficult things that you're trying to manage at home. You will feel depressed, and you will feel like you just don't have any energy. So when we look now at the problems that are being managed, obviously it's depression, the rates per 100 encounters, okay? Depression, anxiety, sleep, etc. So in looking at what's happening in Australia in the Medicare subsidized encounters, percent of patients and the rate per 1,000. So when we start looking at this age group, we are seeing a lot of these folks being taken care of with Medicare dollars. And this just broke it out by states or territories. So it's Victoria, Victoria has the most, but they're pretty even, okay? So you can find where you're living and see how that looks statistically. Okay, so the medications that are prescribed are antidepressants, followed by anxiolytics, and I really want to, do you find your primary care folks prescribing a lot of alprazolam? A lot of tranquilizers? No. Yay, that is a very good thing. So what we were having a great problem in the United States is about 85% of tranquilizers are being prescribed in primary care. Xanax is the classic one. And then they get addicted and they send us to psychiatry to get them off the addiction. So if you can help stop that, because anxiolytics are useful for the very short term. But if that anxiety is being driven because the woman is afraid to go home, she's going to get beat up by her husband or vice versa, then medicine isn't going to fix that. Okay? And a lot of people will talk to me about what's going on and say, you've got to give me something to feel better. And I go, I can't medicate your husband. Okay? Or, your kids are, if the kids are substance abusers, I said, I can give you, some medicine that might help you deal with this a little bit better, but it's not going to fix the problem. So trying to motivate people to take action and make some changes in their families is what's really important. So here's the referral sources: psychologists, psychiatrists. I don't see any psychiatric nurses on this list of who gets referred to, so I have to fix that statistic in the next go around. Okay. So what are these? These are illnesses. So these are a few scans from the National Institute of Mental Health in the United States, the NIMH. Okay, one of the things that we know is that, our cortex, a little review from anatomy and physiology. And how am I doing on time? Murphy, will you tell me when I'm supposed to be done? We started late, right? Did I start about 15 minutes late? Okay. I know that you want to get to tea, and me too. So, all right, just a few slides left. But these are important to look at. So your cortex has 6 layers to it. When you're born, only 4 of those layers are mature. The other 2 layers mature usually by about age 2, and we can tell when that happens by the presence of speech. So when the child goes, me want ball, then we've got a subject, a verb, and a predicate. Then you've got all the layers of the cortex up and running. So that's just a little tidbit. But we have big differences here. So the area of greatest activity is in the red. So what we see here in a normal control, we see a lot of activity in the cortex. And these upper layers, the outer layers, are what feed the information to the cranial nerves, and the lower layers are what feed up from the body. So they sort of meet. So the cortex is continually getting input from inside the body and outside the body. And that's what we see in these scans. But look what we have in bipolar disorder. So in bipolar disorder, we do not have a very functional cortex. So this person is going to think, yeah, I can go out and, tell somebody to, go fly a kite. I can tell my boss that he's stupid. I can go spend, money that I don't need to worry about because somebody else will give me more money. So we see a lot of errors in judgment. Well, this is why. Because the cortex is offline in a bipolar state. And these are really important. You can print these out and you can show them to the patients and explain to them. I mean, nurses, we like to teach people about what's going on in their bodies. So when we look at unipolar depression has a lot of problems in the lower part. So what's feeding in from the body isn't being used by the cortex. So when people have super major depression, they don't take care of themselves, they don't eat right, they have zero energy, okay? And we can actually see that, and yet they will tell you, because the outer, what's feeding from the outside, will say, I know my house is a mess, I know my kids need to be taken care of, I can't do it. I can't get my body to do it. And this is the perfect picture of that. So this is what feeds the external. I can see the environment, but I can't make my body do anything. In schizophrenia, it's not too bad, but there is problems here in the feed from the external world. So people will misperceive that external world in schizophrenia. Schizophrenia is a disorder of salience, in being able to filter what's coming from the external world and have that make sense so that it's the same for the person who experiences this as it is for everybody else in the environment. So we can see from just this picture of just the cortex, which doesn't even talk about what's structural. So here's an MRI, and we're looking, here's the nose. So this would be the right hemisphere, this is the left hemisphere, and here's the person's ear. And we've got our ventricles here, which circulate cerebrospinal fluid. This is the frontal lobe. This is the prefrontal lobes, and this is the temporal lobe. So here is where we make decisions. Here is where we go, okay, should I make that decision or not? And here is where our auditory center is, but also right down in here is where our mood center is, and our memory centers are hooked in right over here. Do you see a problem in this picture? So what jumps out at you? Somebody holler at me what you think looks significant in that picture. Shrunk. Bingo. That's a good word. Okay. So what we have, it's called cerebral atrophy. So we see that the frontal lobe, and this is a mess. Okay? So if you tell this person, and they have schizophrenia, and you tell them, okay, if you don't take your medicine, this is going to happen in a few days. That brain absolutely cannot comprehend time. It cannot comprehend cause and effect reasoning. Okay? So if what I do today, that doesn't mean anything. So you talk to a patient, and they'll say, well, I stopped taking my medicine a couple of weeks ago. That doesn't have anything to do with me having symptoms now. They can't make that correlation, okay? So we shouldn't lock somebody up and put them in restraints because of this. But in mental health care, we don't get a brain scan for our workup, do we? I mean, if you're cardiac, if you're respiratory, if you're anything else, you get this full workup before anybody does anything. But oh no, you're having some type of symptoms that affects perception, which is your sensory, cognition, which is the way you think, emotions, which is the way you manage your perceptions, and then your relationships. So if we look at that, they call it behavior. Say, oh, really? Okay. Well, what goes into behavior? Cognition, perception, and emotions. So if we could get simply a brain MRI to see, do you have all your parts? Yeah. And so we're supposed to be writing treatment plans, we're supposed to be engaging people, doing patient education, and we do not know what their brain looks like. So this person is going to need a lot of care. This person probably isn't going to make it on their own. This person, if they're discharged from a large treatment center, will probably end up homeless, mentally ill. Okay, now we're going to look at the back of the brain. So in this one, here's the right hemisphere, here's the left, and here's schizophrenia from the back. But look at this. This is a Vietnam vet. So a lot of folks with PTSD have psychotic features, and this is why. And the theory behind this is the fear, the anxiety of being in combat. It causes you to start pumping out cortisol, okay? And we all know the TV commercials, the cortisol that gives you the belly fat. Okay, well, it's toxic to the brain, and it actually causes destruction of the hippocampus, which is where our short-term memory is located. So when we see people that don't act right, they're not responding right to our terms, we're not inside their head. So what I've learned, and I'm so grateful for those early years on neurology that I was forced to work in, because it gave me such great appreciation for what people struggle with related to, head injuries or any other type of brain tumors, Parkinson's, anything that can cause neurological damage can cause psychiatric symptoms. So now to look at a PET scan. So the other one showed a structure. Let's look at function. So this is glucose uptake. And what we're seeing, so this scan would be if you would take my head off and you would look up, okay, at about ear level. So that's what we're looking at inside the brain. So what we see here, so here's the frontal, here's the prefrontal, here's the temporal, and this is occipital. This is the back part of the brain. These are the ventricles. And this is the thalamus. The thalamus is our central computer unit in your brain. All incoming sensory information goes first to the thalamus, with the exception of smell. But all other visual, auditory, olfactory, tactile, and gustatory taste goes to this structure. Then this feeds information up here, which is called the basal ganglia. The basal ganglia then the basal ganglia are responsible for filtering this information then up to the frontal lobe. So there's all these circuits that are happening in the brain. So green means the structures are there. Yellow means they're ready to receive an impulse. Red means it is receiving an impulse from either internal or external stimuli. So now look at this poor patient. Okay, so this is the function within schizophrenia, and this is a very typical person with schizophrenia not on any medication. So what we see is that the structures are there, the green, okay, on this side of the room, the structures are there, but there's not much yellow, so it's not really ready to receive impulse, and there's minimal red going on, except there's a lot of red at the bottom over in here, and what that is that's sensory information, visual, that hasn't been processed yet by the thalamus. So all incoming information, including visual, has to go through the thalamus to be processed to get up here to the frontal lobe. So, but if the thalamus isn't on duty, then this is like backed up visual input. So if any of you have had the experience, I'm sure you have, you sit down and you're doing an intake and you do know that maybe this person has a psychotic illness and you might have eye contact for 5 seconds, 10 seconds, and then glaze over. Okay, and that interview is pretty much done. And you go about asking questions and you don't get any answer. And how many of you had the experience that maybe half an hour later, if you were still with the patient, they came up and answered one of the questions that you asked? That's delayed information processing, and that's what we're seeing here. Okay, this is obsessive compulsive disorder. And this is a really very horrible illness. So this is the person, I can't stop washing my hands kind of thing. And what we know the pathology there is within that basal ganglia, in that the information that the frontal lobe gets is that, you washed your hands, but your hands are dirtier after you washed them than before. So that is a very serious illness that we primarily have behavior modification approaches that are more helpful than medications. So what's a potential solution? I thought I had my depression picture in there. If we were looking at depression, it would be completely blue and with nothing lit up in it. So the good news and bad news about depression is that it gets better whether it's treated or not. The bad news is that it can take up to 4 years after therapeutic response to a medication, depending upon what's going on in the person's 24-hour world. So what's our solution? Put a primary care nurse in every GP clinic. And put a nurse practitioner there, and let nurse practitioners run the clinics. That's my solution. Okay. So what are some roles? Listening, 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 listening. Participating in treatment by engaging in care management. So care management is case management, having, do a lot of home call, do home visits, calls, bring patients in together to do smoking cessation groups, those kinds of things if you're not already doing. Learn all you can about the brain. Differentiate between mental illness and mental health problems, okay? Look for what we call the AMPs. Is your person being amped up? So AMPs, this is our little acronym for mental health care in primary care, which is looking for anxiety, mood, psychosis, and substance use. So if you screen all your people for this and you do an ACEs score, you're going to have so much data, and your patients will love you because they think that you care enough to ask. And treat them as you would treat any other patient. Screen all. So you'll have this website. Develop your relationship, fight stigma, fight stigma, fight stigma, fight stigma, and think about what we call the new field of positive psychiatry, not just positive psychology, but positive psychiatry. And in positive psychiatry, we are thinking about suffering. We want them to, suffering from symptoms before they get the mental illness as opposed to just treating them afterwards. Positive attributes and strength. Look at a person's protective factors, what's happening in their brain physiology, and think about recovery. And last but not least, you've got so many great practice resources here in your country that it's really a privilege to read and study about Australia. We can learn a lot from you. And I just encourage you all to not be afraid about addressing mental health needs and start with looking at trauma. And if you can do that, you will probably save somebody's life. So thank you very much.
Beautiful. Thank you so much, Dr. Mary Moller. I love that. Did you love that? We could listen to you all day. We don't have all day, unfortunately. In fact, this break is going to be 1 second. But what a fascinating session. I wish we could open the floor because I'm assuming that everyone would have a million questions. Does anyone have something burning that they would love to ask Dr. Mary while she's in the room? I know you're sticking around for the break, so we can come up and have that conversation one-on-one. No burning questions? Be brave. Be bold. This is your chance to have your voice heard. Okay, great. Good on you. I love it. I'm coming down. What's your name?
Mary.
This is Mary. Everyone say hi, Mary.
Hi, Mary.
Stand up, Mary.
I was just wondering about the correlation between marijuana use and schizophrenia.
There is no such thing as a safe joint when you have schizophrenia. One joint and even the passive secondary smoke can create a psychotic episode. And many of our young people who are experiencing hallucinations start using drugs in particular because it will give them a reason to hear voices. Okay, so the self-medication is often done to, like I said, to justify. And it's so serious. One of my young girls I worked with for a long time when I was in Eastern Washington got her really stable. She absolutely could not be around marijuana. And she decided she was just going to, go to a pot party and smoke pot. And she ended up in the hospital for, I think it was about 12 weeks. And so she comes out, and I was really stern. And I said, so, because you wanted a joint, we just had to spend $65,000 in taxpayer dollars because you wanted a joint. She goes, wow, I never thought about it like that. I said, I know. So it's not safe. It is not safe. It might be legal in the United States, but it doesn't mean it's safe. All our government wants is the tax dollars. That's why they legalized it. So, no,
great. Thank you, Mary.
Safe.
And thank you, Mary.
Yep.
We do only have time for one question. We have a lovely gift for you, Mary, on behalf of the APNA team. So thank you so much. Join with me in thanking Dr. Mary Moller again.